Welcome to today's webinar on Pharmacogenomics in 2018, Current Applications and Future Opportunities. I'm Dr. Ann Moyer, and my colleague Dr. John Logan Black will also be presenting for today's webinar. Here is a slide showing our disclosures. The objectives today are to summarize basic concepts of genetics and pharmacogenomics, to describe testing modalities currently available, including the limitations, explain evidence-based applications of pharmacogenomics testing, list appropriate uses of single gene and panel testing, and to recommend new tests and tools that increase the utility of pharmacogenomics. Recently, a study was performed at the Mayo Clinic that involved about 1,000 patients. 5 genes that are important in the metabolism of many drugs in pharmacogenomics were tested, and among those 5 genes in those 1,000 patients, 99% of them had a variant in at least one of the genes. So really what this tells us is that pharmacogenomics could potentially be relevant to pretty much all of the patients that you will be seeing in your practice. And so today let's talk more about that. So we'll start out with some basic concepts of genetics and pharmacogenomics. One thing that's really important to keep in mind is that there are many factors that impact the response to medications. Today we're going to be talking about pharmacogenomics, which is the genetic variation that underlies potential differences in response to medication. But as we talk about that, always keep in mind that all of the other factors that you've historically been thinking about as you've been prescribing medications or working with patients are still all going to be very important. Anything from the age of the patient, sex of the patient, diet, the different comorbidities, other medications or compounds that they would be taking, drug interactions. But again, pharmacogenomics is one of those pieces as well, and is definitely going to be important. So what exactly is pharmacogenetics all about? It's really to use genetic information to predict how well an individual will respond to a drug. So historically, pharmacogenetics is typically used to talk about single genes or a few genes at a time, whereas pharmacogenomics is usually talking about genome-wide variation. But at this point in time, the terms are typically used pretty interchangeably. But the goal of all of this is really to aid clinicians in selecting the right drug in the right dose at the right time for each individual patient. So what does this really look like? So we have a chart here which shows drug concentration on the y-axis and over time on the x-axis. And basically what you can see is the green line would represent the medication concentration that the patient would be taking. The goal is that you really want to keep it in the therapeutic window, which is between the 2 dotted lines. If the concentration gets a little bit too high for the patient, then you might end up with a situation where you have toxicity. And if it's too low, you might not have efficacy of the medication. So really you want to keep between these 2 lines. And so normally the patient will take a dose, the drug concentration will go up, and then over time it will decrease as the patient metabolizes the medication until the next dose. And so this would be for a normal metabolizer or what you're hoping will happen for your patient. But now for some patients, they might not metabolize that medication quite as quickly as the average person. And so as you can see, if they're not metabolizing the medication quite as quickly, over time with each dose, they might get a little bit higher dose than you had expected or higher concentration and eventually creep up into that toxicity zone. In contrast, a patient that metabolizes the medication a little bit too quickly might end up with a lack of efficacy because the drug concentration would not end up in the therapeutic window for them. And so what's really exciting about this is if we actually knew which group a specific patient would fall into, then we could use that information to alter the dose of the drug or perhaps even select an entirely different drug. And so that's really what pharmacogenomics is all about. One thing that's really important to note is that each individual patient can fall anywhere in a spectrum of activity. So at the lower end, some patients are poor metabolizers, and in this case they have severely decreased or absent enzyme activity. And usually these patients are going to be homozygous for a genetic variant that would inactivate or result in an inactive enzyme, or they could be compound heterozygote. There are also the normal or extensive metabolizers. So if you look at older literature, you'll see the term extensive, which used to be a little bit confusing. And so now we've moved on and we call these patients normal metabolizers. And they just have the average or normal enzyme activity of the general population. And so you would be expecting that you could give them a normal dose of a medication. In between those 2 categories are the intermediate metabolizers. And then on the other end of the spectrum, we have some patients that are going to metabolize a medication more quickly than expected, and these would be the rapid metabolizers, all the way up to the ultra-rapid metabolizers. And again, the actual category that an individual patient falls into can be predicted by genetic testing, but again, these aren't necessarily completely discrete categories in that some patients might fall between categories, and so you would see that reflected on the reports. So it gets a little bit more complicated than what we initially showed you with that graph of the patients having faster or slower metabolism, in that there's different types of drugs. So the drugs that you normally are thinking of are the active drugs. The patient would take the drug, it's in the active form, and then it would be converted to inactive metabolites by the enzymes. And so if you had someone that was a poor metabolizer, so again they had a very deficient enzyme activity, they might end up with too much of that medication and potentially have toxicity. So an example of an active drug would be warfarin, which is metabolized by CYP2C9 and then eliminated. And on the flip side, though, some drugs are actually prodrugs. In this case, they're ingested in the inactive form, and then they have to be converted to the active form by the enzymes for therapeutic action. And so in this case, you really have to think about it the exact opposite way, in that a poor metabolizer in this case isn't going to be able to make enough of the active form of the drug, and therefore they're going to end up with too little of the drug or too low of a dose, potentially. So a couple of examples here would be codeine, which is converted to the active metabolite morphine by CYP2D6, or clopidogrel, which is converted to its active metabolite by CYP2C19. So in addition, the metabolizer status gets a little bit more complicated than that even. So along with the genetic variation, remember that patients could be taking other drugs or foods, and some of these things can also impact drug metabolism. So some medications or foods could be inducers of an enzyme, and so they would basically increase the enzyme activity. And in this case, they might increase the expression of the gene encoding the enzyme or impact the binding or activation of the enzyme. And an example of this would be phenobarbital with CYP3A4 induction. On the flip side, some medications and chemicals could be inhibitors that would decrease the enzyme activity. So a common example that you may have heard of here is grapefruits or grapefruit juice with CYP3A4 inhibition. And so basically these additional compounds can also, in addition to the genetic variation, have an impact on how the drug would be metabolized in the individual patient. So just a little bit more in the terminology for you. There's a couple of different pathways that we talk about in pharmacogenomics. So there's the pharmacokinetic side, and that's what the body is doing to the drug. So these are things like the absorption of the medication, how it's distributed throughout the body, how it's metabolized, and how it's eliminated. And on the flip side, there are also pathways that are the pharmacodynamic side. And so this is what the drug is doing to the body, or really the mechanism of action of the drug. And this would be a lot of the drug targets. And just for a few examples of this, for some of the pharmacokinetic genes, these include a lot of enzymes that are going to be metabolizing the medications, like the cytochrome P450s, TPMT, NUDT15, DPYD, and several transporters such as SLC01B1 and SLC6A4. But these are just some examples, and there are many more genes that are also involved in the pharmacokinetic side. Now on the pharmacodynamic side, so again, this is on more the mechanism of action, we've got for warfarin, one of the targets would be the vitamin K epoxide reductase complex, so VCORC1, and then also you can see the serotonin transporter, SLC6A4, comes up. So these aren't mutually exclusive in that some genes could fall under both categories. And then in addition to the pharmacokinetic genes and pharmacodynamic genes, there's really another subset that doesn't really fit very well into those two categories. So we've got the HLA genes, or major histocompatibility complex genes, and these are involved in toxicity of some medications. And I think we'll be hearing more about that a little bit later on. So a little bit more on how the pharmacogenomic testing actually happens and some more specifics on that. A couple of the questions that really come up pretty regularly are, well, who and when should you test, and which tests should you be using? So we're going to talk a little bit more about that. So to start off with, for the when to test, we're going to talk about the differences between reactive testing and preemptive testing, and then we're going to go into some more details about some of the different testing technologies. So in terms of reactive testing, this is really what you've been historically doing for a lot of tests that are done in the laboratory or that are ordered for patients. And with pharmacogenetics, this is really kind of the historic type of testing. So it's done at the time that the patient needs a medication. And so basically at that point in time, there's a specific clinical question that needs to be answered, and the test result would be used to guide the dosing or perhaps the selection for that specific application or that specific question at that point in time. So typically only one gene or a couple of genes would be tested that would be specifically used to answer that clinical question. And you might use the results again in the future if another medication came up that might be metabolized by the same gene, or you might not use the results again in the future. And so this is pretty much the common bread and butter of pharmacogenomics testing that's been going on. But there's something that's a little bit newer right now. So there's been a little bit of a transition with preemptive testing. And what this is in contrast, the testing is done before the patient needs a specific medication, and then you can use the results to guide the future prescriptions. It's kind of handy because you don't have to wait for the test results to come back. The test results are already there so that they can be used. But the hard thing about it is you don't know exactly what medication the patient is going to need in the future. So these tend to be panel-based tests that are a little bit larger, that have many genes on them that would be applicable to many different medications, so that hopefully whatever the patient takes in the future, this test would be useful for. But the challenge of preemptive testing and why it's really coming up now more than it used to in the past is that you really need that information to be readily accessible to the future providers, and that they really need to know it exists. Because if that testing has been done on the patient, but you can't really find the test results, or they're not readily available when you're going to prescribe that medication, you can't really use them. So towards the end of the webinar, we're going to be talking about some of the tools that have made preemptive testing a reality and a possibility at this point in time. So currently, there's really a mixture still going on. Some patients or providers will have the reactive testing at the time the patient needs the medication, and in other situations, some groups, some providers are moving to preemptive testing of their patients so that they can use these results in real time as the patient needs them. So a little bit more on the different types of tests. We have a chart here that shows a various number of genes down in the first column. And then basically each of these additional columns shows the different types of tests that are available, at least through our laboratory. And so the first column is really the single gene tests. And as you can see, there's quite a wide variety of tests that are available for individual genes. And so basically, if you were going to be ordering pharmacogenomic testing in the reactive setting, you'd need to know what particular genes are relevant for the medication that you're interested in at this point in time, and then you'd want to select the appropriate test that would cover that particular gene. But in some cases, we're starting to know more and more about the medication metabolism and realizing that there might be multiple different genes involved, so we also have some small panels. So for instance, with the thiopurine medications, TPMT and NUD-T15 are tested together because both of them are important in the metabolism of these medications. Or for warfarin, we're up to 4 particular genes that are included in that test at this point in time. But then in the last column, you can see that this is an example of a test that would be potentially used more in the preemptive setting, or could be used in the reactive setting as well, in that it tests multiple different genes that could be important in the metabolism of multiple different medications. So if you had a specific clinical question today, and you knew that the gene that you were interested in was on a larger panel, you could test the patient for that panel right now and answer the question that you have today in the reactive setting, but then you could use that testing going forward. So if you're going to select a test panel, the important thing to note is just make sure that you're using or selecting a test panel that has the gene that's going to answer the question that you have today, if it's not done exclusively in the preemptive setting. So now I just wanted to give you a little bit more information about some of the types of pharmacogenomic tests. So on the last slide, I didn't really mention it too much, but there are a couple of our single gene assays that are available as either a targeted genotyping assay or as a sequencing assay. And depending on the application, you might want to pick one or the other. So it's important to know really what are the differences between these two types of tests. So on the top, you'll see a targeted genotyping assay. And basically that blue line represents the area of interest. So it's going to be either the exons of that particular gene or something along those lines. And then the orange arrows are the specific positions that would be tested for in this test. So a targeted genotyping assay is going to only look at the specific variants that the test is designed to look for. In contrast, the sequencing assay is going to identify all of the variants within the region tested. And so you see a little yellow mark there. That's an example of our particular genetic variant. And so in this case, in the targeted genotyping assay, if that variant is at that position, you'll note that there's not an orange arrow pointing to it. So that means that that position was not included in the targeted genotyping assay. So basically, the test would not be able to detect that variant. So it will miss variants that are not included in the test design. And this could be a problem if that particular variant alters the enzyme or the protein. In contrast, in the sequencing assay, again, it's going to pick up everything in this area, so it would be even able to identify a rare variant, like this variant. And the challenge of that, though, is if there's limited clinical information available about that particular variant, it might be difficult to interpret the results. So the nice thing about the targeted genotyping assays is they're typically less expensive at this point in time, and they typically have a quicker turnaround time. So they definitely have some advantages. But on the flip side, the sequencing assays are becoming less expensive, and the turnaround time, although it's typically longer, that's improving as well. So you'll probably start to see more sequencing assays available in the future. But I would say that the majority of the pharmacogenomics tests that are currently available on the market tend to be targeted genotyping assays at this point in time. But depending on the specific gene, you might have options. So now I just wanted to highlight a little bit more that I mentioned a few minutes ago that there are different tests that have different genes included. Well, even if you found two different tests that had the same exact genes included, the tests might not be identical. So when you're looking at a targeted genotyping assay, again, it's going to only include the particular genetic variants or positions that the assay was designed to detect. So on the top, you can see a TPMT genotyping assay that only has a few SNPs. So you can only see those 3 orange arrows. Versus on the bottom, there's a TPMT genotyping assay that has many more SNPs. You can see that there are many more orange arrows. So why would this really be important? Well, let's say that the patient has this genetic variant denoted by the little yellow symbol. Well, on the top assay, you can see there's an arrow there, and yep, it's been detected, and so this result would be a star 2 allele. And on the bottom, that test also detected that same variant, so the result, again, would be a star 2 allele. So that's great. Both tests would give a comparable result. But now what happens if instead the variant is down here? You can see that on the top assay, there's not an orange arrow by that particular yellow variant. So in this case, this variant would not be detected by that assay. And in pharmacogenomics, if the variant is not detected, the result will be a star 1. So star 1 is typically what's resulted out in the absence of finding genetic variants. Star 1 isn't necessarily a result that indicates that something in particular was found. And on the bottom assay, because this particular variant was included in the assay design, it can be detected. So in this case, the correct result of a star 8 would be reported out. So let's say, for instance, you had a patient that came into your office and they had results from 2 different laboratories, the lab on the top, or with the assay on the top, and a lab with the assay on the bottom. They might end up coming in with 2 different results. So it's really important to understand how exactly the test was done and what it included. And if you ever have questions on that, that's something that you could potentially run by your laboratory, or you could always give us a call about that, and we're happy to chat about some of these technical details. But they're definitely very important, and it's just good to know that not all tests are identical. So one other thing to note is that as more variants are included in the test, the sensitivity of the test increases. And so one thing that gets a little bit confusing for a lot of providers is that because there are many laboratories out there, both academic and commercial, that are performing testing, and I just showed you that there's variability in the genes that are tested, and even when you find a test that includes the same gene, the alleles that are tested might not be identical. But in addition to that, the reporting structures often vary. Some labs will report out very gene-centric reports, so they'll show you the genetic variants that they found in the particular genes, but not necessarily a lot of details on the medications. And other laboratories will provide a lot of details on many, many different medications, and the genetic information will be there also, but they have different fields to the types of reports that would be available. But there's also variability in the medications that would be included in the report. And one other thing that's important to note is depending on the institution that you're at, the results from testing from some laboratories may be integrated into fields in the electronic health record, or perhaps from some other laboratories, they may just be returned as a PDF. And so this can be kind of important to know about because clinical decision support alerts are something that's very helpful, and again, those are going to come up a little bit later in the talk. But if the results are not available in discrete fields in the electronic health record, it can be a lot more difficult to implement clinical decision alerts. So it's a little bit tricky just because there's so much variability out there. But I think the main pearl that I would like to pass on is just if you're ever going to be ordering the testing and you have questions, it's a good time to ask perhaps the laboratory or other resources. But it's just important to make sure that you select the test that has the genes that are going to be important to help with your patient. Because basically if you select a test that has 200 genes on it, but it doesn't have the one gene you needed to answer your clinical question, you're still not going to be any further ahead. So it's just important to know that there are differences and pick the most appropriate test.
Thanks, Dr. Moyer. Well, let me add my thanks to you joining this webinar. It's a very nice turnout, and we're really pleased to have a chance to talk with you about pharmacogenomics. We looked at the registrants, and we also looked at the questions that you submitted as you registered, and this whole talk has been tailored to meet that need, to try to answer as many of your questions as we can in this short 1-hour session. One of the questions that was very prominent was, what's the evidence? And this is a question we commonly get, and we look for, we use specific sources as we're building our tests, as we're keeping up with the field, which moves very rapidly. I can't hot link out to these sites, but those are the web addresses, and we promise that we will send you these presentations with links so that you can use these in your own practice if you choose. One of the most important publishers of practice guidelines is the Clinical Pharmacogenetics Implementation Consortium listed here. They have published at least 50 drug-gene pair publications which show the utility of pharmacogenomics for those specific drugs and how an individual might, a clinician might use that data to advance their practice. Somewhat before they even started to work, the Dutch Pharmacogenomics Working Group did some publications, and that's linked as well. As far as I can tell, they've been mostly incorporated into CPIC at this time. Various professional societies also have published, like the American College of Rheumatology on HLAs associated with allopurinol toxicity. And then there's the Pharmacogenomics Knowledge Base, or PharmGKB. Now this one's a little more researchy. However, they have great diagrams, and you'll see some of those as we go through the rest of this presentation. The diagrams are superior. They actually give you an idea of which genes are involved in metabolizing. You can see the pathway, and it's very helpful to know that on some occasions. Then there's the FDA. The FDA commonly comments on the metabolism, of course, of the medications in the labels. So the labels are approved by the FDA. They have to have some information on how the drugs are eliminated. Usually the cytochrome P450s are a feature here, but there may be others, and those are listed. The best way to get to that is to go to DailyMed. You go to DailyMed, you type in your drug name, select it from the drop-down, and you're going to be able to search on, for example, CYP for cytochrome P450s or whatever other gene you might be interested in. They also published at the FDA a pharmacogenomic biomarkers in drug labeling table. It has over 150 entries at this time, and it shows where these pharmacogenomic annotations are in the actual drug label for those drugs. And then finally, we have a really nice associations table that we're very proud of, and we hope that you'll go out and take a look at it, maybe even download it, put it on your desk, and use it as you practice. And it's our Pharmacogenomics Associations table, which includes a lot of information about many medications, the cytochrome P450s that are involved in metabolism, what inhibits and what induces the CYPs, cytochrome P450s, as well as information on G6PD, glucose 6-phosphatase, which is another pharmacogene that's very relevant with certain medications. And then we have a final table that includes information about other genes than the CYPs, and one more table that shows drugs that largely are not impacted by the cytochrome P450s. When you do this type of work and you do this type of review, then you start to very quickly see that there are some really strong genes associated with drugs, or gene-drug associations. For CYP2C19, for example, clopidogrel, which we'll go over in a minute, citalopram, and the tricyclic antidepressants are relevant. And again, I'll go over all three of these. For CYP2D6, tamoxifen is relevant. Tamoxifen is another drug that is activated by CYP2D6. And so if an individual is using tamoxifen to prevent breast cancer recurrence, if they're a CYP2D6 poor metabolizer, or even an intermediate metabolizer, their risk of having a recurrence is higher than if they were a normal metabolizer. That's really relevant because there are other medications that can be used. Codeine and tramadol, both activated by CYP2D6, and then fluoxetine, paroxetine, and fluvoxamine, as well as the tricyclic we'll go over in a few minutes. Couple others, SLCO1B1 is associated with simvastatin myopathy. I'll talk about that. SLC6A4, which is a serotonin transporter, is the target of the serotonin reuptake inhibitor class of antidepressants, and there's a variant in that which impacts response. Serotonin receptors 2A and 2C are also associated with antidepressant response as well as antipsychotic-induced weight gain and metabolic syndrome, and I'll touch on those in a few minutes. Warfarin, as Dr. Moyer already mentioned, there's 4 targets there, and TPMT and UDT15 for the thiopurines, and DPYD for 5-fluorouracil and capacetic. I can never say this one, but you can read it. So those are the ones that really are prominent. There are others, but these are the ones I wanted to highlight for you, given the attendees at this conference. Then finally, we get into the HLAs, and I will touch base on those as well in a few minutes. So the first one I'd like to discuss is CYP2C19 and clopidogrel. And this is actually one of those diagrams that came right out of PharmGKB. It's used with permission, as are all the diagrams in this presentation. And you can see the clopidogrel is metabolized through a 2-step process. The prominent enzyme involved is 2C19, and it is required to be an active enzyme for this drug to be activated. Clopidogrel, again, is a prodrug. It's not active, so it has to be converted to an active state. What's the evidence? Well, the main use, or the main research, I should say, has been done on acute coronary syndrome, ACS, patients who are undergoing percutaneous coronary intervention, or PCI. And the research broadly supports that patients who have a STAR2 allele, and a STAR2 is a null allele, it's an allele that does not function. And as an aside, let me just say, many of the alleles have what's called a star nomenclature, STAR1, STAR2, STAR3. Usually STAR1 is the normal or the wild type allele. STAR2, it's just easier to say STAR2 because it might be a culmination of 3 or 4 variants in the same gene that make up a STAR2, and it's just easier to say STAR2 than to list off 3 variants. So the STAR2s are inactive, and if a person's heterozygous or homozygous, they'll have reduced clopidogrel activation. And there's substantial evidence linking genotype with clinical outcomes in ACS-PCI. And this was really done nicely. It's a bit of an older article, 2010, but the article by Mega showed that, it was a meta-analysis, showed that the hazard ratio for an individual who is a heterozygote for STAR2 is 2.67, and a homozygote for STAR2 is nearly 4. So those are numbers that are getting there. Now, you might think that you could just increase the dose of clopidogrel, and you probably can, although the jury is kind of out on that. Dose escalation study was done, and they found that you had to get to 150 milligrams of clopidogrel for a STAR1, STAR2 patient that's a heterozygote for STAR2 to really get appropriate platelet inhibition, and 300 milligrams per day for a patient who was homozygous for STAR2. Oftentimes, it's just easier to switch medications, and we'll get to that in a minute. Now, as Ann was saying, as Dr. Moyer was saying, not all tests are created equally. We really pride ourselves in managing to care for patients from a broad and diverse ethnic background. And when you do that, you have to start reaching into other alleles that have no function, similar to the STAR2. So we do that, and we have quite a number of them on our test. Now, I'll say that all of them are reduced or null, meaning no activity alleles, with the exception of STAR17, which has increased activity. and it is relevant, and I'll just speak to that right now. So your lab should provide you with, the alleles that were found. They'll usually give you a star allele. Your lab should give you the expected phenotype, in other words, normal or ultra-rapid or poor metabolizer. And it's fairly easy to deal with this particular drug-gene pair, and that is if you have anything less than a normal metabolizer, the patient should be switched to a different antiplatelet drug, and prasugrel and ticagrelor are two candidates for that. Yes, individuals who are rapid metabolizers or ultra-rapid metabolizers may have some increased risk of bleeding, so you need to monitor for that. The next drug gene pair I want to address is SLCO1B1 and the statins. And these are a little small, but I hope you can see them. Simvastatin is in this cluster, and it's transported into the liver once it gets through the intestinal cell and into the blood. It's transported into the liver by SLCO1B1, where my pointer is here. If there is a defect in SLCO1B1, there are higher concentrations of simvastatin in the blood. That gets to the muscle. It impacts the muscle in some individuals and causes a myopathy with elevated CKs and everything else. So it's, this is why this one is relevant. We also know that this drug is metabolized in the liver by CYP3A4, and there actually is a target there at STAR22 and any other deficiency alleles. We have that test, but I'm not going to focus on it other than to just mention it. Once the simvastatin or other statins are in the liver cell, they do their action. They reduce cholesterol formation, and it results in lower cholesterol. So if the patient can't transport this into the liver normally, there's a risk that they're going to get a myopathy, and the drug may not work as well. So what's the evidence on this? First of all, this is known by a couple other names. They're listed here. There's this one variant, C521, which is found in these three star alleles. And it has been associated in large studies with statin-induced myopathy. And I list them off here. There's a search study of 1,200 patients, the heart protection study of 20,000 subjects, and then a strength study of 9,000 subjects. Taken together, the odds ratio for myopathy is about 2.3 per copy of the variant, which is the C allele. Atorvastatin may be similar, but the associations have been weaker, and so we're not really totally comfortable making that association at this point, but you may see some other labs do that. So how do you do the results? How do you use them? If the patient has one or two copies of a STAR 5, 15, or 17 CPIC recommendations, that group that publishes practice guidelines I mentioned, says don't exceed 20 milligrams of simvastatin or consider an alternative, and there are many that you can choose from. If you choose to have a patient on it while they've got one of these alleles, simvastatin, then you can certainly monitor CK and watch for signs or symptoms of muscle soreness that would lead you to think that they have a myopathy. The next gene I want to discuss is HLA-B5801 and allopurinol. Now, allopurinol is broadly used for hyperuricemia, and when a patient takes that medication, they can develop severe cutaneous adverse reactions. There's been a strong association that's been found between those side effects and the presence of the HLA-B5801. These are interesting because there are three or four of these that we'll talk about, but the HLAs are not only a marker for risk, but they play a pathogenic role in causing scar because they present antigens to C cells and initiate adaptive immune responses which give rise to this phenomenon. Well, what's the evidence here? There's associations that were first found in the Han Chinese. It's been replicated in Japanese, Korean, Thai, and French populations, and the odds ratio between these studies has ranged from 29 to 580. Now you're really getting there with some odds ratios, so this looks like a pretty strong association. Now the trick about our population in the United States is that we have such an interesting and unique admixture of ethnicities. You can't always assume knowledge of the risk based upon a presumed ethnicity. You don't know when somebody's going to be at risk just based on ethnicity. Yes, this appears to be more commonly associated in Eastern populations, but found in France as well. So I think the allele does have some ethnic stratification, but it is found in several different ethnic groups. Other factors are if you have renal dysfunction in your patient, or if they're taking ampicillin or amoxicillin, they're at even greater risk. What are the testing recommendations? Well, even in the Taiwan Department of Health for Chinese patients, it's not mandatory, but they recommend it for patients going on allopurinol. Our own recommendation is that the testing be done because the severity and mortality of SCAR is pretty high. And testing should be considered even more strongly if there's a family history of this. How do you use the results? It's pretty simple. If the patient has the allele, don't give them allopurinol. If they're already on allopurinol and they're tolerating it, you can continue it, but watch them. There's a similar risk for these types of hypersensitivity reactions between HLA-B5701 and abacavir, as well as HLA-B1502 and HLA-A3101, and several anti-seizure medications, carbamazepine, oxcarbazepine, and so on. You can see them there. And it's a similar picture. Abacavir is a little bit different, but a SCAR-type picture is very prominently associated with the use of carbamazepine and related drugs, so it's another reason to test. Warfarin response panel is another panel that we have. We're really proud of this one. It really does reflect the latest practice guidance, and it looks at 4 genes: CYP2C9, VCORC1, which is the actual target for warfarin, CYP4F2, and this intragenic locus, which is associated with response in African American populations. I'm going to kind of walk you through some of the evidence, and I'm going to show you how this works, because I have a diagram that shows the interrelationship between the various genes. So the UPAC trial was done, and it was a European trial, and they found that using pharmacogenomically guided treatment led to shorter time to stable dose, improved percentage time in therapeutic range, and fewer episodes of INR over 4, which is a dangerously high level, or INR, I should say. The COAG study, which was done in the United States, included African Americans, and it only looked at STAR 2 and 3. And now we're going to get into a little discussion about ethnicity and the impact of having the right alleles on board when you're doing the testing. They did not include STAR 5, 6, 8, 11, nor RS12777, which is that intragenic allele, and these are found in African American populations. So if you're not looking for it, you're not seeing it, and it can impact the validity and outcome of your study. And then there was another study called the GIFT study, which looked at outcomes where thromboembolism, major hemorrhage, INR greater than 4, and death were the outcomes, and they found that pharmacogenomically guided approaches were accompanied by a 27% reduction in those outcomes. So how does it work? R warfarin and S warfarin are, well, when you take warfarin, this is what's in it, R and S, but S is active. Warfarin interacts with VCORC1. That is its effector. It inhibits VCORC1 activity. VCORC is responsible for reducing vitamin K, which then goes on to activate clotting factors. So, S-warfarin is metabolized by CYP2C9. If you have impairment in CYP2C9 activity, you're going to have more of the drug, which is going to interact more with VCORC1, and it's going to reduce the amount of activated or reduced vitamin K, so you end up with poorer clotting factor activation, a higher INR. VCORC1 can also have variants, and the variants can reduce the amount of VCORC1 produced and in some cases, can lead to warfarin resistance. So you can get both ends of this stick. On one hand, you got somebody who has a promoter variant that cannot act, results in a very low concentration of ECORC1. So normal doses of warfarin will wipe that out, and you won't get any vitamin K processing. And then on the other hand, you have some people where there's something wrong with the active site for warfarin. It doesn't interact properly, and to get these people anticoagulated, you have to use heroic doses of warfarin. Then there's vitamin K, which is the reduced form, which is metabolized away by CYP4F2. If there's something wrong with this enzyme, you have excessive concentrations of reduced vitamin K, which drives towards more activation of clotting factors. So you can see how all of these features fit together and help us to know how to manage our patients. Now, warfarin dosing is complicated, and y'all know that if you're practicing in the field and you're using warfarin. I know a lot of people switched over to drugs like apixaban and so on because it's easier, but some people still like to use warfarin because they're used to it and they're comfortable with it. But there's warfarindosing.org is probably a pretty good site to go to. We use it occasionally here, but it's not completely complete. So the latest guidance is shown here. And this is what came out with the CPIC guidance, and it actually walks you through how to deal with your pharmacogenomic results. And it breaks it out by African or non-African ancestry, and it takes into account the fact that this intergenic locus is relevant to only African populations, and it kind of gives you an idea of how to adjust your doses. This is what our report looks like. It basically tells you what was found and then guides you in on how to use that. Now, as far as the antidepressants go, I'm going to kind of buzz through this because I know there's a lot of psychiatrists that are on the line, but I want to touch on this because I think it's real important work, and well, I am a psychiatrist, so. So the tricyclics, there are two genes that are relevant there, 2C19 and 2D6, and the serotonin reuptake inhibitors, there's a few more, as you can see. So we'll walk through these. In the first case for tricyclics, now I know most people don't use tricyclics for depression anymore, but I've been around a while, and sometimes, you know, when you're treating patients and they're not responding to anything, you kind of have to look at all options, and you may end up with a patient on a tricyclic. Fortunately, we know the drug levels for those that are effective, and there's data that points to improved clinical outcomes and reduced rate of treatment failure and drug changes if you use pharmacogenomics. But there is not a great number of large clinical trials. So you rely upon the pharmacogenomic testing to help you get to a drug level, which you're going to check anyway. So you can use it for that purpose. It may help you to avoid, for example, a CYP2D6 poor metabolizer is going to have a really high amitriptyline level if you give them the usual doses. So you'd want to be careful with that patient and not use the usual doses. If you're using this for pain, and a lot of people do use the tricyclics for pain, or chronic pain, pharmacogenomic testing is of no benefit. Don't do it. You're using too low of a dose. It's usually like amitriptyline, 25 milligrams, 50 milligrams. I mean, sometimes you can get in trouble at 50 milligrams in a poor metabolizer, but usually you won't. This is what the diagram looks like for metabolism. Amitriptyline, the heavy hitter here is 2C19. There it is. And for nortriptyline, it's 2D6. So, of course, nortriptyline is active. You can prescribe it. So amitriptyline is converted to nortriptyline mainly by 2C19 and then 2D6 for nortriptyline to its inactive metabolites. How do you use it? A little more complicated. There's two genes involved. Your laboratory should provide you with some guidance on this, but PharmGKB does have an online tool that you can use with medication dosing. I encourage you to go and look at that. You can just search it. And then the CPIC guidance is also available, and I've listed that below here, Dr. Hicks' article. As far as the SSRIs go, we have a little more evidence, but mostly it is from industry. There's a more extensive body of evidence, but in a few clinical trials that provide the basis of SSRI pharmacogenomic recommendations. And one trial which came out of a company I have a conflict of interest with, I'll just say that right out, is AssureX, and their algorithm showed improvement in both remission and response rates if you use pharmacogenomics, savings from a medication perspective, as well as avoiding total healthcare costs. And here's a couple of examples. This is for fluoxetine. And fluoxetine is interesting because it's also an inhibitor of CYP2D6, but it does get metabolized by it. So it's metabolized, that's the main metabolizer to these two metabolites, this one being the active metabolite. And then it's cleared further through glucuronidation. And then we've got the citalopram. Just citalopram by itself is a mix of S and R. S is the active. It's metabolized primarily by 2C19. So if you have a problem with 2C19, you're going to want to use a lower dose. And then there are other enzymes like 2D6 that are involved in downstream metabolism. Mention of a couple others before I hand it back over to Dr. Moyer, but HTR2A variants are associated with response and side effects to SSRIs, mainly citalopram, escitalopram, and HTR2Z variants are associated with weight gain. Those are both serotonin receptors, weight gain with antipsychotics. And then the serotonin transporter, SLC6A4, is a promoter, has a promoter variant. They're both long and short variants, and carriers of the short form have been shown to respond more poorly to SSRIs and might guide you to use an SNRI as opposed to an SSRI. Now, historically, pharmacogenomic tests have been available as single gene tests, as Dr. Boyers mentioned, but now panels are becoming available. We have multiple panels that you'll see out there that you can purchase for your patient. You can order for your patient, and they're being done because of complex metabolism, or you're trying of a particular drug, or you're trying to decide among different drugs which one is the best to use for your patient from a pharmacogenomic perspective. Or if you're like here at the Mayo Clinic, where the average patient, I'm told, comes in on 13 drugs, you've got this polypharmacy component, and you're trying to figure out how best to manage patients overall on multiple medications. And you can also use it for preemptive testing. So Dr. Moyer has developed our larger panel. It's called the Focus Panel, and I think it's appropriate to let her talk about that.
Thanks, Dr. Black. So I just wanted to give you a little bit of an overview of what our Focus Panel looks like, because you may be interested in using panel-based testing, and just having an idea of what one of them looks like can give you some opportunities so that you can compare depending on what's offered at your institution or your laboratory. So for our Focus Panel, basically we started out by reviewing the top 200 prescribed medications, both a list from just those of patients at Mayo, but also a list of patients across the U.S. And then of those 200 medications, we looked for well-established pharmacogenomic associations. And for those where we were able to find a well-established pharmacogenomic association using the evidence that Dr. Black just talked about in the last section of our webinar, then those genes that were associated with those particular medications were included on the panel, as well as recommendations in text format for each of these medications. And then in addition, we included other medications, even if they aren't commonly prescribed, but they have well-established pharmacogenomic associations with the same set of genes. And then finally, we added on a few additional genes that are involved in the metabolism of many drugs. And so these might be helpful if you're looking at some of the secondary pathways, or you're looking at a more complex problem. And then all of this was packaged into hopefully a user-friendly report. And we'll show you that in just another slide. But basically what we ended up with is 10 genes that cover 55 medications, and they really cover many specialties. And here you can see what the list of genes is. And really these genes, I think, are the ones that are going to be the most broadly applicable to many, many medications that your patients may be taking. So if you're looking for a panel, these are ones that I would definitely recommend including in your testing. In the end, the test included 82 alleles across the 10 genes, because as Dr. Black mentioned earlier, we like to make sure that our tests are ready to go for patients of many different ethnic groups, and that we will be able to capture the alleles that are maybe rare in Caucasians but might be common in other groups. And so this is really an important aspect in the testing, as we mentioned earlier, that testing for more variants increases the sensitivity of the test. And so here's what this looks like. And you might see reports from other laboratories as well, but hopefully you'll see something similar, in that there will be usually medications listed and then perhaps a recommendation to help guide you as to what you should do with that medication. And we also are including some symbols to make it a little bit quicker. So in this case, the medications are in alphabetical order so that you can find the medication of interest more quickly. And then if it has a little green check mark by it, we're usually telling you that the standard dosing should be recommended for your patient. But again, remember, there were all of those other variables that we talked about at the very beginning of the presentation. So always keep all of those other variables in mind when you're looking at the pharmacogenomic results and put together the whole picture for the patient. But then for other medications, you'll see a little triangle that might tell you a little bit more information about that particular medication. And then further down in the report, you'll see the information about each gene. So you'll get a genotype, and then that's where you'll see the star alleles that you heard about earlier. And then you'll see a phenotype, which also was that spectrum that we talked about earlier, from poor metabolizer to normal metabolizer all the way up to the ultra-rapid metabolizers, and a little bit of more general information about that particular gene and phenotype. And as you can see, the focused pharmacogenomics panel included quite a few medications in the end, and so the list is here. If you're curious to see more details, you can look for your favorite medication when the slides come out later. But there are definitely a number of them that are covered. But if there were ever questions, certainly it's possible to interpret the same information for other medications. But if they're less commonly prescribed, or it's something that maybe the evidence isn't quite as strong, we didn't want to include that in the report. But depending on the patient situation, it's something that you can always talk to the laboratory about a little bit more to see if you can get some guidance for your patients. So the next thing I really wanted to talk about is something that I find really exciting. So this is some tools to facilitate the use of pharmacogenomics. So as we mentioned before, there are a number of different tools that you can use to look up some information. So if you wanted to use warfarin, for instance, there's the warfarindosing.org. And I think CPIC is doing a fantastic job. They've been putting out a lot of guidelines for medications where there's really strong pharmacogenomic evidence. And the guidelines are very well written so that you can go to them, you can see what your patient's pharmacogenomic genotype and phenotype are, and hopefully you get some good guidance there for how to prescribe the medication. They don't necessarily cover whether you should do the test or you shouldn't do the test. That's really out of the scope. So this is more if you're going to do the test or you have the results, how to use that information. But I think that by looking at that information and seeing how strong some of it is, I think you can get a sense that for many patients this could be extremely helpful. And again, Dr. Black mentioned the Pharmacogenomics Association table, and that can really help you figure out what genes might be important to test for your particular patient. But the thing that I'm especially excited about is this potential migration from the reactive testing to the preemptive testing. And as I kind of alluded to earlier, there are a number of things that are making this a possibility. So the reactive testing has always been very helpful for patients in that you can get the testing done, you can figure out what to do at this point in time. But the real value of the preemptive testing is that you could presumably get the testing done once and then use that information for quite some time until either the testing evolves and we've got a number of more genes included, or until there's new information coming out that eventually you may need to repeat it. But you could probably use that information for quite some time, and then you don't have to wait for the test results to come back. But again, this can be really tricky if your system isn't set up for that. So the things that you really needed to make this happen is to have a way that you can find those test results more easily. And I think really having the electronic medical records available at this point in time and some of the capabilities of those have really helped facilitate this, so you can put the result in and be able to find it again. And then also at some institutions there's incorporation of best practice advisories or clinical decision support alerts into the electronic health record. And this is really nice because basically when you're ready to prescribe the medication, potentially this alert could pop up and give you some guidance right in real time. And I'll show you an example of that in just a minute. So the guidelines are very helpful in use of the information, but again, there's a little bit of limited guidance on when to order. But another thing that's been really helpful is that many institutions, pharmacists are starting to play a larger role, and they can help facilitate the use of pharmacogenomic information. Now, at your specific institution, you'd need to check along with your pharmacist to see if they're comfortable with this, because this isn't something that all pharmacists have had a lot of exposure to at this point in time, but it seems to be integrated more and more into their training programs. And at least at our institution, the pharmacists tend to be very excited about pharmacogenomics as well, and they can definitely be great resources, especially since they're so used to dealing with all of the drug-drug interactions and all of those other variables that pharmacogenomics fit in with. So even if you're not performing pharmacogenomic testing in your local laboratory, sometimes the local laboratory can also be familiar and aid in test utilization and test selection. Otherwise, if they're sending it out to a reference laboratory, then the reference laboratory can hopefully fill this role to help as well. And clinical decision support alerts and just-in-time education are also very helpful, but again, they really have to be set up or created, or obviously they won't be available. So here's just an example of what we have at Mayo Clinic at this point in time with a number of different genes, and you can see the drugs that we have clinical decision support alerts available for and the years that they were introduced. And so we're getting to have quite a large menu, and these are the ones that have very strong, solid pharmacogenomic evidence, but I think this list will be growing over time. And just an example of what that looks like, if the provider tried to prescribe the medication, they might get an alert like this that says, oh, well, your patient's actually an ultra-rapid metabolizer, and so maybe you don't necessarily want to use that acetaminophen codeine tablet, and then it'll have a link with more information. And so these are something that are becoming more widespread at other institutions as well, so you can check to see if this is a capability where you are. And again, here's just an example of what that educational material will look like at that link. So this is something that's in Ask Mayo Expert at our institution so that someone can get a little more information in real time before they have to go to the next step and call someone for some additional help. And so I know one common question that comes up in our last couple of minutes here is the cost of testing and insurance coverage. And I guess this is a really tough question to answer just because the clinical tests are highly variable in the cost depending on where you're located and what laboratory is doing the testing and which specific test you're looking at. So they can cost anywhere from the hundreds of dollars up to the thousands of dollars. And so it's something just to check into probably before ordering if it's something of concern. And in addition, the insurance coverage is also quite highly variable. If you review the coverage information that's available online for some insurers, you can see that there's quite a bit of variety and that some will cover testing if it's necessary for clinical decision making. Some insurers consider all of it to be investigational or experimental and don't want to cover very much of anything. And others will cover some testing for very specific indications, but may or may not cover it if it's part of a panel. So it's so variable that it's really important to look at the specific insurer that would be covering that patient's testing before making any generalizations. And so we did try to put a little bit of information in here, and in the interest of time, I'm going to skip through this, but you can refer to the slides at a later date because we'll be sending these out. But basically this gives you an idea for private insurance, what we've been able to find just in general again. And then similar for CMS coverage, that some things are generally covered and some may not be. But again, it's important just to look into it as you go through for your specific patient. So again, it may cover a single gene, may not cover a panel, may cover either. So it's just always important to have a conversation with the insurance company to determine the coverage. So in summary, pharmacogenomic testing is available to guide medication therapy. And there are now a lot of guidelines, really through a lot of the efforts of CPIC and the Dutch Working Group that are available to help use this information. Single gene and panel tests are clinically available, and there are sometimes a number of different options depending on the specific gene and clinical indication. And the insurance coverage, again, is highly variable. And so with that, I just wanted to make sure that everyone's aware that at Mayo Clinic we have an Individualizing Medicine conference coming up in September where we will be talking a lot about personalized genomics. And as part of that, there's a pre-conference, so if you'd really like to learn more about pharmacogenomics and want to make a trip here to Rochester, which is beautiful in September, there's a pre-conference that's devoted to pharmacogenomics for the modern healthcare team, and both Dr. Black and I will be speaking at that as well as a number of other speakers. So there's definitely, you can look into that for some more information. And I don't know if we have a lot of time for questions here, but if you've got questions, you can always let us know by email, and we'd be happy to answer them. But thanks again for tuning in with us.
Thank you so much, Dr. Moyer and Dr. Black. I know we're right at the top of the hour. I assume a few people have to take off to get to different meetings. Do you have time for a couple questions?
Sure. Sure.
Okay. Appreciate that. So at this time, we would like to take any questions that you may have. If you'd like to ask a question, please submit through the chat function on the CenturyLink web application. For participants joining in the audio-only portion of this webinar, please press star 7 to unmute your phone. Once you have finished asking your question, press star 6 to mute your line again. And I know we did have a couple come in during the presentation. Let's see.
There was one that was asking if we have an API to help with pharmacogenomics decision support, and yeah, we do internally, but we are not marketing that at this point. There may be something in the future for that. Now, we're in the Epic system newly, and they have the capability of building out something like that, and we've been in some discussions with them on it, but we haven't really gotten all the way there. So at this point, there isn't. But there's been some work within MML to provide support within Mayo Medical Labs to provide support for this type of a function. So stay tuned. We may have something in the future that we'll be able to share.
Thank you, Dr. Black. There's also a question about physicians are asking about what updates are received once a PGX test is performed. And I assume this is getting at after the initial testing, if there's maybe new associations discovered in the future, how can people stay up to date on these?
Well, currently with our testing, if you were ordering it, it would be coming back into your discrete fields, and then that test result would be basically time-stamped with the date that the testing was done. And so you'd want to be, basically, if you were going to be using it soon in the future, things probably wouldn't have changed super quickly, but as the test report gets older and older, it might get to a point where it might be useful to call the laboratory and ask if there's a particular gene or genotype that you're interested in looking at for a particular medication. Just talking with the lab to see if there have been any changes in that, because sometimes things do get updated over time, and we would recommend retesting a patient who's already been tested, but in some situations things haven't changed and you can keep reusing that result. So it's really kind of on a case-by-case basis, I would say.
And we do update, I think as you've implied, we update the Pharmacogenomics Association table, and people can refer back to that for additional information.
Thank you for participating in today's specialty testing webinar. I just wanted to note as well that laboratory credit is extended for this program. And upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. So we'll just finish by saying, again, thank you, Dr. Black, Dr. Moyer, and if you have any other questions, please feel free to reach out to us.